Great. So for those of you who don't know me, I am Patty Taylor. I am the Director of Quality and Patient Safety in the Community Health Collaborative at the Hospital Council Foundation. So our sepsis committee has made a goal of providing CNE presentations throughout the year. Unfortunately, most of you did see my notes, at least I hope you did, that we unfortunately found out late Friday afternoon that this presentation was not approved for CNE. So we will not be offering a CNE, but I love that all of you still showed up because this is going to be a great presentation. We all want to learn. We want to learn new things. We have a great speaker lined up. So we really appreciate you joining us today. So at this time, I'm going to introduce Matthew Crotty, who is our speaker. He is an infectious disease clinical pharmacist at Methodist Dallas Medical Center. He received a BS in Food Service and Technology from University of Nebraska-Lincoln before obtaining his Doctor of Pharmacy from the University of Nebraska Medical Center. He then completed PGY1 Pharmacy Practice and PGY2 Infectious Disease Residencies at Barnes Jewish Hospital in St. Louis, Missouri. His research interests include the epidemiology of antimicrobial resistance and antimicrobial stewardship practices. Woo, that's a mouthful. So Matt, thank you so much for agreeing to talk to us and educate us and share your knowledge with us. I will go ahead and turn it over to you at this time. Thank you, Matt.
Thank you for the very nice introduction, Patty, and thank you all for being here today. I'm going to discuss antimicrobial stewardship on maybe some new ideas, concepts, things of that nature. I've obviously, really devoted my professional career to antimicrobial stewardship, so it's certainly a passion. And so hopefully at the end of this time, you'll walk away with a few tidbits that will be helpful to your practice. And I'd be happy to, join in a conversation and answer any questions towards the end. Before I get started, I do have a couple of disclosures to make. So I've acted as a consultant for bioMaru, which works primarily in the laboratory space, and I don't think I'll mention any of their specific technologies today. And then I do have research support through investigator-initiated study through Paratech Pharmaceuticals. I will not be talking about that particular study, that particular drug, but these are recognized disclosures to make here. So our objectives today, hopefully by the end of this talk, you'll be able to discuss current and future application of antimicrobial stewardship to improve patient care, and then describe safety issues with key antimicrobials, and then mitigation strategies related to kind of minimizing some of these safety issues. And we'll focus in on spectrum, so spectrum of activity, as well as duration of therapy and how these all interplay to make drugs either more dangerous, more risky versus more safe. And so that'll be a key focus throughout all of my slides here. So how we hope to accomplish these objectives is outlined here. We'll start off with kind of the landscape related to standards for antimicrobial stewardship. And we'll talk about some of the key next steps or targets that have been focused or outlined. Then we'll move more into antibiotics, and we'll talk about why they should really only be used when they're absolutely needed. And then really the bread and butter, the meat and potatoes, I suppose, of this talk will be safety focused. And so we'll talk about spectrum of activity, safety of these drugs, and how duration and all of these things kind of work together, with a couple of key focuses on C. diff, vancomycin plus piperacillin tazobactam and acute kidney injury, and then cefepime neurotoxicity. So before we begin, I want to lay out kind of the logical thought process here related to why I'm speaking to you today, why I've made this kind of my focus of my career, and that's that overall we need to improve use of antibiotics, and the reason we need to do so is that antibiotics are frequently misused in the hospital. I could say in clinic settings, in EDs, in all sorts of outpatient environments, in veterinary medicine, in agriculture. We use an awful lot of antibiotics and antimicrobials in our world today, and it can have negative impacts if we're not judicious with that use. Misuse can directly not only impact a single patient, but this is a shared resource, and I think I'll reference that again later. And so, misuse in one patient can actually impact all of us, and so it's a societal burden and issue. The counter to that is that by improving antimicrobial use, we can improve patient outcomes, and this again can be on the individual level as well as a larger societal level. And then finally, we've reached a point where this is really a health emergency, a public health emergency. And so I think there's a tremendous amount of focus from governments and agencies and things, trying to bring light to an issue that's been creeping up and has really reached a breaking point at this time. So to put some numbers to it, I think most of us would recognize that there is misuse of antibiotics. I'm sure many of you on the call today have specific examples that you could point to where antibiotics were not necessary, were overused, were inappropriately used. But I think putting some real raw numbers to it is pretty impressive. And so this is some data that's been out there for a while. I think it was first referenced in 2014 that about 20 to 50% of all antibiotics prescribed in acute care hospitals in the US are either unnecessary or inappropriate. More recently, analysis in this past year have continued to find that of that range, we're probably on the upper end of it, somewhere between 40 and 50% of antibiotics are misused or inappropriate. And there's a variety of different ways that this happens. It can be related to antibiotics being given when not needed, continued for longer than necessary, that duration piece that we'll talk about later, the wrong dose or drug for the specific infection, oftentimes using too broad of a spectrum when a more narrow spectrum agent could be utilized. And so, clearly there's an issue of misuse. And so, trying to improve upon that is the ultimate goal. This was a nice paper that was done back in 2019. This idea has been adapted to subsequent kind of promotional activities through the CDC, but the original paper was from Pranita Tama in 2019, and it breaks antibiotic use down into kind of 4 key steps and has specific clinical questions that should be answered whenever an antibiotic is being utilized. The first is, does the patient have an infection? And does that infection actually require an antibiotic? The second is, have we done the appropriate cultures or diagnostics to evaluate that particular infection? And then as you're answering yes to these questions, yes, the patient has an infection, yes, we've gotten the cultures, et cetera, what is the appropriate agent to start empirically? And a lot of times I think this is a difficult question. There's growing resistance in the world, and so it's kind of the natural reaction to be broader with our antimicrobial therapy, but that can be ultimately quite detrimental, which again, I'll allude to and get back to here in a few slides. Step 3 is after some time has passed, we start to get results or we see the patient progress. We can determine whether the antibiotics need to be continued or if they could be safely stopped. Could they be narrowed? Did we start broadly for sepsis? We've now identified a specific pathogen and can narrow down the spectrum of therapy. And then also, can we consider oral agents rather than leaving them on an IV antibiotic? And all of this, interplays together to try to optimize things as we get new information. And then the last piece, which again will be a focus a little bit later, is that duration piece. What we've continuously found is that shorter is often just as good as a longer course of antibiotic therapy. And more, we found that long durations of antibiotics are one of the major risk factors for resistance. And so not only do we get the same kind of benefit in treating an infection with a shorter course, but we also can potentially mitigate some of the detrimental effects of antibiotic resistance by using shorter courses. Misuse and overuse of antibiotics directly impacts patients through antibiotic resistance. It can, as I've alluded to, it's a growing and emerging issue in public health. And I think one of the kind of dilemmas with this problem is that it's not only a specific patient that's impacted. It's not even only a specific hospital unit or a hospital that's impacted, but it really is a societal issue. And so if we misuse antibiotics in single patients on a routine basis, ultimately we're going to breed up resistance and cause problems for all of us, so that antibiotic is less effective in treating an infection down the road in potentially a different patient, including myself or you and I later on. And so I think that societal impact is what's really interesting about antibiotic resistance. Again, like I mentioned, there's a lot of focus on antibiotic resistance. And so these are some of the CDC numbers from their antibiotic resistance threat report published in 2019 or updated in 2019. And you can see here, in the US each year, there's almost 3 million antibiotic resistant infections and more than 35,000 deaths related to resistance. Additionally, there's another more than 200,000 cases of C. diff and almost 13,000 deaths related to C. diff. And so clearly a major burden to us currently. Additionally, although we have seen promising trends related to resistance in certain areas, there's a lot of trends that are really bad, or for lack of a better term. And so highlighted at the bottom there, erythromycin resistant or clindamycin resistant group A strep, drug resistant gonorrhea, and then ESBL or extended spectrum beta lactamase producing Enterobacteriaceae. These are E. coli that are highly resistant against most of our key first line agents. And these are a tremendous issue, and resistance in that capacity continues to increase over time. And so into this world of trying to optimize antibiotic use to try to deter unwanted side effects and the continued growing problem of resistance is antimicrobial stewardship. So essentially, antimicrobial stewardship is an idea, a logic, rational, systematic approach to the use of antibiotics in order to achieve optimal outcomes. And specifically, it's about using the right drug at the right dose for the right duration, right? And so we're trying to optimize use to mitigate the negative consequences while also optimizing the outcomes of individual patients. And it can be a difficult balance, and we'll try to highlight some of those issues as we move through these slides. The ultimate goals of antimicrobial stewardship are to optimize clinical outcomes for an individual patient while mitigating those unintended consequences such as toxicity. And so toxicity can present in a whole host of things, whole host of different ways. I will key in on a couple of, maybe highlights of those toxicity issues, but there's countless different problems that can occur when we use antimicrobials. And that includes not only misuse of antimicrobials, but even when we're using them appropriately, all drugs do have side effects. And so, there's always that potential dilemma. The second part is, trying to mitigate resistance and ultimately super pathogens from forming, such as C. diff. I think, it would behoove me to have an antimicrobial stewardship talk that didn't focus a little bit on C. diff, because that's really the epitome of what antimicrobial stewardship's goal is to mitigate something like C. diff from happening. And so into this landscape of antimicrobial stewardship and resistance, there's a fair number of regulatory bodies that have put forth standards and recognized different capabilities that all hospitals should have related to antibiotic stewardship. Essentially, both CMS and the Joint Commission have taken part, made some mandates and standards related to antimicrobial stewardship, but really fall back to the CDC for guidance. And so I'm going to key in on just a little bit of that. So CMS, has outlined a few things related to stewardship and what it should look like. And they do make specific reference to having programs at all hospitals and focusing in on deadly diseases like C. diff and antibiotic resistance. Additionally, they spell out that we should have kind of internal guidelines that reference national guidelines as kind of the placeholder for optimizing therapy, and then kind of work towards those goals. Joint Commission essentially has several different standards in place. I would say the vast majority are directly related to CDC's core elements, which I'll show here. And they went into effect about 5 years ago. And so all of these kind of standards fall back to the core elements that were outlined by the CDC. I think it's been almost 8 or 9 years ago. And essentially they outline kind of 7 key pieces of antimicrobial stewardship that each institution or each acute care hospital should have. So there should be leadership commitment, and this can be shown through dedication of resources to antimicrobial stewardship, accountability, so there should be a specific leader at the hospital kind of taking the charge for antimicrobial stewardship at that facility. There should be drug expertise. So, people like myself and many other pharmacists or others with expertise in pharmacy can also be integral parts of this kind of team and process. And then when we get into the nitty-gritty of what we're really doing, we should take action to make direct change and improve antibiotics. We should track that change in antibiotic use and resistance over time. And then we should report it back to staff, let them know what's going on, how to improve, and then ultimately educate them on what best practices are and how we can improve as a whole. And so these kind of core elements of antimicrobial stewardship are really the playbook for optimizing therapy in the hospital. That being said, we're getting farther and farther into it, where a lot of hospitals have been doing antimicrobial stewardship for some time, have implemented a lot of really good pieces to improve prescribing and utilization of antimicrobials. And so it's kind of turned towards what is the next step? How do we continue to advance? How do we continue to improve? It's not to say that we have everything figured out and ironed out, because certainly we don't. I think that many institutions are still working on some of these core elements, still have many initiatives that they would like to see come to fruition related to antimicrobial stewardship. But at the same time, there's many programs that are well established. And so the next pieces that are focused on, or should be focused on, or should be a focus, as outlined by the Joint Commission, are specifically diagnostic stewardship, which we'll come back to and we'll talk a little bit more about here momentarily, which is really addressing the errors of diagnostic decision-making that ultimately lead to antibiotic prescribing or inappropriate antibiotics prescribing. One of the best examples of this is in the urinary tract, and so we'll talk about that here momentarily. The second kind of key intervention that's outlined as kind of a next step or a best practice from the Joint Commission is handshake stewardship. And the way I like to think about this is, traditionally or historically, antimicrobial stewardship was seen as maybe antibiotic police, where people would be told no to a certain drug or no to a certain combination of therapies or something like that, and there'd be a policing that happens. Traditionally, that was done behind a computer screen. As we become more and more in a virtual world, many people at my own institution may not see me on a daily basis. And so I think trying to break that mold, to put face-to-face as much as possible, maybe not in the midst of a pandemic, but trying to dive through things on a more personal level, discuss specific patients and how to best manage those issues that arise, can go a long way in ultimately educating and improving practice on the whole. And maybe it's a good time to say, just because we're oftentimes working virtually and things doesn't mean that handshake stewardship can't happen. I think the idea is really for it to be more personal, but I do think that the real idea is to key in on individual cases to help move through or work through individual challenges that come up in implementing stewardship strategies, rather than it truly being just a face-to-face or a true handshake that happens. So, I'm going to shift gears just a little bit and move towards the actual antibiotics and what I mean by optimization, what I mean by trying to mitigate, the risk. And it starts with only using antibiotics when they're truly needed. And there's a concept of colonization versus infection that can be really challenging. And so I'm going to try to explain as best I can what that really means. essentially, microbes such as bacteria are all over us. They're all over our body, including on our skin, in our mouth, in our GI tract, etc. They're everywhere. And so, a lot of times we look at treating infection as like, kill off all the bacteria. Well, what we found is that's not a good strategy. Ideally, you're directing antibiotics towards the specific infecting bacteria while really leaving the rest at peace, right? So, bacteria do a lot of good for us, and disrupting the microbiome of our bodies actually has a lot of negative consequences, not only infection related or resistance related, but things like cardiovascular disease and neurologic diseases have been directly connected to disruptions of the microbiome. And so I think we need to move away from the kind of thought process of like, kill everything, kill all the bacteria, to maybe mitigate what the infecting bacteria is doing, or direct our therapy only at specific organisms that are causing a problem, while trying to leave the rest in their normal circumstances. Additionally, when we talk about colonization, it's not only on the body, but I work in a hospital. I'm sure many of you do as well. There's microbes all around us. And so specifically on things like devices, so plastics, hardware, metal pieces, there's bacteria on that. And so trying to separate out what is colonization, what is normal versus what is truly causing an infection, and can be a little bit challenging sometimes, but the ultimate goal is not to try to destroy all bacteria, but rather to identify what the specific issue is and direct our therapy towards that. The last piece about using antibiotics only as needed is that, traditionally we're talking about antibiotics, we're talking about antibacterials. So things like penicillins, et cetera. And these are really these are really only for bacterial infections. And so they shouldn't be used for non-bacterial infections. And maybe this is a good time to point out, in the context of a ongoing pandemic, that most antibiotics, antibacterials, do not have activity against viruses. So things like flu, COVID-19, et cetera, are not going to be impacted dramatically or not be helped. We're not going to be successful in managing those types of viral infections with antibiotic therapy. And so we shouldn't use them for those situations, because that is ultimately, one, unnecessary, but also leads to undue problems. And so I'd like to spend a little bit of time and talk about this kind of colonization versus infection concept as it relates to the urinary tract. This is an image from the Get Smart for Healthcare campaign that was done almost 10 years ago by the CDC. But I think that's still, pertinent information and gets us set in motion here. And so what they highlight for urinary tract infections is that they specifically spell it out. They say, make sure that culture results, so urine culture results that are positive, represent true infection and not just colonization. And the best way to do that is to really assess for symptomology. If a patient doesn't have specific symptoms of a UTI, then ultimately they shouldn't be tested. Their urine culture should not be collected and tested and trying to grow specific bacteria. And so one way to look at this, or one way to think about this, is to look at the prevalence of bacterial colonization in given populations. And this is a table that tries to summarize the prevalence of asymptomatic bacteria, or essentially the presence of bacteria in a patient that does not have an infection. And what you see is, if you start at the top here, a healthy premenopausal woman would have a likelihood of 1 to 5% of growing bacteria if we were to culture their urine. So if we had 100 healthy women and we cultured their urine, about 1 to 5 of those patients would grow out some bacteria. If you shift down to look at maybe diabetic patients, you can see that the prevalence jumps pretty dramatically. And so now we're talking about maybe 1 in a quarter, 1 in 5 of these patients will grow a bacteria, even though, again, all of these represent no infection. If you then shift to elderly patients, again, instances increase, and I highlighted here patients in elderly patients in long-term care facility. We're talking about potentially a prevalence of 1 in 2, right? So 50% of patients now growing bacteria, again, even though there's no actual infection. And then the last one to highlight is dialysis patients or patients with a urinary catheter. The likelihood is that they will grow a bacteria. So if they're cultured, expect it to be positive. And ultimately, once we identify a bacteria, it's very difficult for clinicians and all of us to kind of ignore that. And so once we put a name to it, I think it's difficult to not treat with antibiotics. And so a better strategy is to attack it kind of upstream and recognize that if a patient doesn't have symptomology consistent with a urinary tract infection, that they shouldn't be tested. Their urine culture shouldn't be collected and tested. And so this is an algorithm that was put together by a group. I think this is about 5 or 10 years old now, but pretty well established. And essentially the idea is, testing patients only if they have specific symptomology related to a urinary tract infection. That can be dysuria, flank pain, suprapubic pain. Where it gets a little more tricky is in things like delirium or altered mental status or in fever. And so it kind of works your way through that. And in those situations where maybe it could be related to urinary tract infection, such as a patient with a fever, but no true symptomology localizing to a UTI, or a patient that's altered, but they can't really localize symptoms to a UTI. In those instances, the general guidance is to try to consider other non-infectious etiologies prior to pursuing a culture. And so, there's a variety of different circumstances that come up. I've spelled out a few here, and I won't go through this line by line just for the sake of time, but I will point out a couple of them. And so in the box at the top, you're looking at urine culture not recommended. And the top one, I think, says it all. So essentially, patients that lack symptoms of a UTI should not be tested. The second part is that a lot of times I think the pan culturing process of sepsis workup is really not well established and not beneficial to patients overall. Frequently, what it means is, we'll get blood cultures and urine cultures, even though the patient doesn't have any symptomology of a UTI. And that can actually lead us astray because we know that colonization is common. We're likely to see a bacteria grow. We may target our therapy at that specific bacteria, even though it's not the actual cause of their sepsis. And I've certainly seen some instances where that was the case and kind of led us astray and led to less than optimal outcomes for the patient. The second part is patients with urinary catheters in the box below can be a real challenge. Again, because colonization is so high, you're almost undoubtedly going to grow bacteria when these patients are cultured. And so there's only a few key kind of patients in the ICU or elsewise where culturing urine in a catheterized patient is a necessity. And so, genitourinary symptoms is the main one, but also patients with kidney transplant, neutropenia, about to undergo a genitourinary surgery, or those who have specific obstruction. And then a patient that's pregnant would be another example. Those are circumstances where, yes, a urine culture is probably warranted. However, for the vast majority of patients, especially those with urinary catheters, it's not. This is just an example of kind of putting all of this together in an algorithm-based approach. This one is from Cleveland Clinic, published a few years back. Essentially, in their ICUs, they came to an agreement that, these are kind of the circumstances in which urine culturing is appropriate, and this is where it's not. And over time, they were able to not only reduce the number of cultures that they obtained, but subsequently also the Crotty rates that they observed in their ICUs. And subsequently to that, less antibiotic use and potentially some of the mitigation strategies that we'll key in on the rest of the way here. I did want to mention this particular slide here outlines one of the statements from the Infectious Disease Society of America, or IDSA. They recently came out with a specific guideline related to asymptomatic bacteria. You know it's a major problem when there's a specific guideline focusing in on the one issue. And so they specifically highlight that kind of key example of a patient that comes in with altered mental status. A lot of times these patients get tested, get urine cultures collected, because we know that, especially in elderly patients, altered mental status can be related to UTI. However, it's always related to UTI. And there's oftentimes things like polypharmacy, other disease states that may be a major factor. And so the IDSA specifically spells out that in those types of patients with altered mental status as their primary presenting symptom, unless they have specific symptomology pointing to a UTI, so dysuria, flank pain, something like that, outside of that, we should look for other causes before pursuing urinary tract infection as the etiology and culturing their urine. Okay, so we've talked a bit about stewardship, resistance as the backdrop. We've talked about, antibiotics being, needing to be more judiciously used and when to use them. Talked a little bit about diagnostic stewardship and how that relates to antibiotics. Now let's key in on the spectrum of activity. And so I'm a pharmacist, and this is definitely one of the main areas that I think I tend to. And part of it is route memorization, unfortunately. And so, I think that a lot of people get turned off by that, and that's fine. This is a schematic that I put together a while back. And the idea is just to point out how broad spectrum a different agent or class of drugs is. And so what you're looking at across the top is the different maybe organism classes. So MRSA, methicillin-resistant Staph aureus, gram-positive, such as strep species, gram-negative, so think E. coli or Klebsiella, Pseudomonas, anaerobes, such as Clostridium or Bacteroides, and then atypical organisms, whether it be Legionella or Chlamydophila or something like this. And so if you look at the different spectrums of these classes of drugs, if you were to compare penicillin across the top, that's a relatively focused antibiotic. If you compare that to maybe a carbapenem, which is a relative, but a very broad spectrum relative, right in the middle in purple. Carbapenems are extraordinarily broad, and about everything except for MRSA and atypicals. And so if you're thinking about, what spectrum do I need? A good place to start is this type of a thinking, right? So, for one, does the patient require empiric spectrum that covers both MRSA and Pseudomonas? Do I need anaerobic activity or atypical activity? Depending on the circumstances, you may or may not. And so I think if you look at this in a nutshell or in a quick glance, you can see that there's certainly narrower spectrum agents, and then there's very broad spectrum agents. And in general, if we can optimize therapy to use a more narrow spectrum agent, the better off we'll be, because we're going to cause less collateral damage that leads to resistance development or some of the other kind of issues that can arise through antibiotic therapy. The other point that I wanted to make here is, I think in the world of sepsis being a driving force behind a lot of antibiotic use, we kind of get tricked almost into thinking that everything is sepsis and everything is a rush to antibiotics. And so certainly timely and appropriate antibiotics save lives. And some examples of the where and how that occurs, the best one is sepsis, especially septic shock or severe sepsis. Additionally, bacterial meningitis, bloodstream infections, or bacterial pneumonia, all of these different infections have shown time to an appropriate antibiotics leads to improved outcomes for the patient. And so there certainly is some level of rush or some level of timeliness that's needed in managing specific infections. However, not all infections require rapid initiation of antibiotics. And so, as I was thinking about this talk, a good example that I think I see relatively frequently in Dallas, Texas, is a patient with a chronic wound, such as a diabetic foot ulcer or something like that, that becomes infected. It's often infected for maybe a few weeks, maybe even a few months before they present to our hospital. And once they hit our doors, oftentimes they're still relatively stable, but it may be a deep wound or something else that requires further evaluation in the hospital. And even though they're clinically septic, we seem to be in a big rush to give them very broad spectrum antibiotic therapy rather than take a step back, recognize that this infection's been brewing for some period of time. And so collecting appropriate cultures, managing wound care is going to be kind of step one prior to jumping to the broad spectrum therapy. And so just as an example, and I think there's several others, not all things are of the utmost urgency. Sometimes it does make sense to try to collect cultures first, to try to do some of these other strategies first before jumping to the broad spectrum therapy with antibiotics. Spectrum plays out in a variety of capacities. I'm going to focus in on pneumonia a little bit here just because there's a relatively new guideline from IDSA related to community-acquired pneumonia. Additionally, I think that pneumonia is kind of a key example of where spectrum plays in and is often, mismanaged or leaves opportunity for improvement. And so one of the things that this specifically addressed was the idea of HCAP, or healthcare associated pneumonia. And they specifically come out and say, we recommend abandoning that terminology, this HCAP terminology. And it was given a strong recommendation in moderate quality of evidence, and it also in joint with the American Thoracic Society. And so they specifically say, HCAP is no more. And if you look at what happened when the previous iteration of these guidelines had come out in 2007, there was a stark increase in utilization of broad spectrum therapies. Specifically highlighted here is vancomycin in green. And so you can see in the years following the initial publication and idea of HCAP, you see a dramatic increase in utilization of vancomycin over that time, to try to combat the risk of MRSA. However, that same time period, you actually see a somewhat decrease, or at least a relatively flat line of the incidence of MRSA. And so there seems to be a clear imbalance or imbalance between utilization of MRSA, vancomycin, and the actual incidence of MRSA. Additionally, there's been multiple studies that have subsequently come out after those guidelines that highlighted that, HCAP did not seem to be beneficial on the patient level. This was a study, a multi-center study, at multiple U.S. hospitals that looked at, patients that got guideline compliant therapy for HCAP versus non-compliant therapy for HCAP. And the guideline recommendation was helpful to patients. We would expect that it would favor the compliant treatment. Unfortunately, what you're looking at here is you see that basically across the board, and highlighted is MRSA, but overall, there was a favoring the non-compliant therapy. And so the idea here is that, by being overly broad, we actually may have brought in some level of inappropriateness and caused more harm than good. And so that's a piece of the puzzle of why HCAP was abandoned. And I think trying to get away from that lingo, trying to get to more specific therapy, less broad therapy, will be beneficial to us all. And I have a couple more examples of how this all plays out in the clinical setting here that I'd like to share. The next study, this one is in a cohort of over 17,000 patients at 100 different U.S. hospitals, where the patients had sepsis and positive clinical cultures. So this could be blood, urine, respiratory, wound cultures, etc. So they had sepsis and a positive culture. And what this group looked at is how many of these patients received empiric broad spectrum therapy that targeted resistant pathogens such as MRSA or highly resistant gram-negatives, and then what was the recovery rate of these types of organisms. So the dark bars represent how likely were these patients to receive an anti-MRSA therapy, a ceftriaxone-resistant organism active therapy, or any highly broad spectrum therapy on the far right. The dark bar is how often did they get these antibiotics, and then the lighter bar is how often were those organisms recovered from culture. And you can see a pretty big disparity in the overall empiric use of broad spectrum therapy and the actual recovery of resistant organisms. Probably more alarming is that they actually found that patients that got inadequate therapy were more likely to have a bad outcome, specifically in hospital death. But maybe more alarming is that in patients that received unnecessarily broad therapy, they too had higher mortality than patients that got essentially appropriate or optimal therapy. And so not only was broad therapy bad just from being overly broad and the spectrum being kind of out of whack with the reality of what was recovered from culture, but it actually was associated with increased mortality. Similarly, another group, this time looking specifically at community onset pneumonia at 4 hospitals in Utah. I think this is all Intermountain Health hospitals or EDs in the Intermountain Health health system. They similarly looked at 2,000 patients with pneumonia and found, one, that resistance rates or resistant pathogen recovery highlighted here by MRSA or antibiotic-resistant gram-negatives were relatively low. Only about 7% in the broad spectrum therapy group had a resistant organism recovered, and less than 1% in the non-broad spectrum therapy group had a recovered resistant pathogen. But again, the more alarming piece is that broad spectrum therapy was associated with an increased 30-day mortality. And the magnitude of this is pretty alarming. So the way that you read this is broad spectrum antibiotics were associated with about a 4 times increase in 30-day mortality compared to non-broad spectrum therapy for community onset pneumonia. And just to give it a little bit of context, vasopressors or vasoactive agents like norepinephrine, which would be used for septic shock, are usually going to be associated with a very high mortality rate. In this particular model, they found that vasopressors were associated with about a 2.5 times increased mortality rate. And that pales in comparison to what broad spectrum therapy was, where it was a odds ratio of almost 4. And so again, a stark contrast between what we perceive is happening with high levels of antibiotic-resistant pathogens and how we treat patients with very overly broad spectrum therapy. And I think, secondary outcomes also point a pretty bad picture here for this particular study. They found that, the broad spectrum therapy was associated with increased length of stay, increased C. diff, and increased costs. And so there's definitely some secondary and collateral damage that occurs too, and can be potentially mitigated by being more refined or judicious with the spectrum that we use. And I think the accompanying commentary with this particular article says a lot. And so it's the title was Potential Antibiotic Resistant Pathogens in CAP, Playing It Safe is Anything But. And I think that's the reality, when we talk about these things, is that a lot of times we practice because we're concerned or we have fear that there will be a resistance, and so we want to be broad. And sometimes that makes a lot of sense, but not always. And you actually can run the risk of trouble the other way. One of the other major factors, at least subjectively, and what I've observed, and I think objectively as well, from data at our own institution or within the literature, one of the major factors that impacts the spectrum that we use empirically is the allergies. So many patients report a penicillin allergy. but it's only about 10% of those patients actually have an allergy. And so trying to clarify those things can be dramatically impactful. There's been several studies that have evaluated the impact of a penicillin allergy on outcomes for a variety of different infections and found that it's associated with worse outcomes for many patients. And so, where we can try to tease this out, try to be more specific with what happened, what agents, et cetera, will help us in being more judicious and appropriate with our spectrum of activity. This is a nice article in the BMJ that spells out kind of cross-reactivity between penicillin, cephalosporins, carbapenems, et cetera, other beta-lactams. And suffice it to say that a lot of times a patient that reports a penicillin allergy is okay or safe to receive other beta-lactams. And so rather than crossing off, all beta-lactams, we should really try to tease out what specifically the allergy is, what specific drug, and what alternatives could be utilized to effectively manage infections in those patients. And for the sake of time, I'm not going to go through this whole algorithm or anything like that. And I've put a box around the area where it says penicillin skin testing because not all institutions have that available. But certainly, there's relatively straightforward questions that can be asked of a patient in trying to tease this out that can be dramatically helpful in optimizing use of beta-lactams in patients that report a penicillin allergy. So I am going to shift my focus again briefly to safety. I think this all comes together, and this is really the focus of my talk, is safety. But for the sake of time, I'm not going to spend a tremendous amount here. But C. diff is a clear issue, and it to me is really the epitome of what stewardship's goal is. Nothing more says we are not being great stewards of antibiotics than the increase and dramatic impact of an infectious diarrhea that's directly linked to antibiotic use. And so, I think that the vast majority of these patients receive broad spectrum therapy. And so as much as we can, we should try to focus on this as a target for mitigation. And the reason that I bring all of this up is if we look at, different classes of antibiotics, they have different risk for C. diff. And so in this schematic here, you're looking at, in red, quinolones such as ciprofloxacin, levofloxacin, and clindamycin as being extremely high-risk agents. Cephalosporins, especially high-generation cephalosporins and carbapenems, as having a moderate risk. And then drugs like penicillins, cyclines being much lower risk. And so if all other things are equal, trying to mitigate, the occurrence or the risk of C. diff is one way to evaluate what optimal therapy is for individual patients. Subsequently, not only is C. diff a problem related to safety with antibiotics, but there's countless other issues. One that's gotten a lot of headlines over the last probably 5 to 10 years now is vancomycin plus piptazo and nephrotoxicity. In my mind, there's no doubt that this combination of drugs increases nephrotoxicity. What I think is more interesting is that we can really mitigate it a lot by, one, not using the combination, but not just replacing piptazo with something else broad, but rather being more judicious in what spectrum you really need depending on the infection being treated. And the second part in the mitigation of this is that the vast majority of these occurrences happen after about 48 or 72 hours. And so short durations of this combination therapy may be okay, may be appropriate, and we can actually mitigate the issue of nephrotoxicity by stopping them relatively early on in the course as we get new information. And so highlighted here is some of the different ways in which we can mitigate that. Again, for the sake of time, I'm not going to spend a lot here, but suffice it to say, there's only a few indications where it's really warranted to treat both with vancomycin and piptazo. The vast majority are managed by a different combination of drugs or an individual agent. And so I think being judicious can really mitigate some of the safety concerns with that drug. The last kind of safety issue that I want to bring to light is cefepime neurotoxicity. I think that, this is caught some attention recently, and so many of you may have heard about this. It is not a new concept, but I think has definitely become more of a focal point recently as we continue to use more and more broad spectrum therapy. The idea is that certain patients are at risk for neurotoxicity with cefepime in combination with high drug doses or inappropriately high drug doses can set a patient up for substantial issues. Signs and symptoms, most notoriously is kind of an altered mental status, even hallucinations, but it can advance all the way to myoclonus, to status epilepticus and seizures, and so can be quite alarming and a major issue. And so trying to mitigate it is appropriate and necessary for us. Again, for the sake of time, I'm going to jump through this just a little bit here, but this was a cohort study done in Switzerland. They did a nice job in kind of highlighting some of the issues here. They looked at a lot of, over 300 patients on cefepime and found, how many of them developed a neurotoxicity, what it looked like, and what were risk factors. Ultimately, the vast majority of patients had confusion, agitation, hallucinations, and only a small subset did it ultimately lead to seizures, but it was not zero, right? And those things when those things do occur, that can be really substantial. Luckily, in green, you can see that the vast majority of these patients' symptoms improved once cefepime was stopped, and ultimately the time to that resolution was relatively short, about a day or two. When you look at specific risk factors for cefepime neurotoxicity, the big ones are going to be ICU, pulmonary and hematologic issues. Specifically, this is, in my mind, related to the drug dose that we would use. So the bigger the dose in a relatively frail patient with maybe less than optimal kidney function, that puts you at a major risk for seeing this cefepime neurotoxicity. And so I think that's something that needs to be weighed and balanced. As we've moved away from maybe avoiding this kind of vanc and piptazo combination to using more cefepime, you may see more of this issue. And I think in reporting it, being cognizant of it, and recognizing it early so that the drug can be stopped and potential major consequences are avoided is necessary. And so I've highlighted here, how can we kind of mitigate this issue? The first question I always have is the spectrum actually needed? Do you need an anti-pseudomonal agent, or could you use something like ceftriaxone? The second part is the dosing strategy, especially renal dose adjustments in patients with kidney dysfunction are absolutely necessary, as higher doses are associated with increased neurotoxicity. And then if we truly move away from cefepime, we use this drug frequently. It's generally well tolerated. It would be a big shift for most healthcare centers to move away from cefepime, and ultimately it would likely lead to more increased carbapenem utilization, which is not necessarily a good thing as we deal with increasing resistance overall. And so the last piece of the puzzle, and as I bring things home here a little bit, is duration. I think for a long time, duration was put on the back burner. We wanted to know what drug kills what, how do we manage, different infections with specific drug therapy. But how long you treat an infection is actually a major issue or a major risk factor for things like subsequent resistance, as outlined by this study by Tishome and colleagues, which demonstrated that each additional day of a broad spectrum beta-lactam increased the subsequent risk of resistance development later on. And so although these odds ratios were relatively small, 1.08, that's for each day. So a couple days adds up quickly in the subsequent risk of major resistance development later on down the road. Shown another way, and from a different study here, it's not only the spectrum that we use, but also the duration. And so this is a study that evaluated risk of C. diff for particular agents over time. And just as an example, if you look at the middle graph there, the purple kind of dotted line there is moxifloxacin, so a high-risk C. diff agent. And then if you see, okay, maybe 7 days of therapy, they had a risk of about 2% or 2 per 1,000 C. diff cases. If you extended that therapy out 14 days, now we see that it's almost doubled the incidence of C. diff. And so not only is its spectrum, but its duration and the combination of the two that can be really important in mitigating some of the negative consequences of antibiotic therapy. What we've ultimately found is that, shorter is often just as good as longer durations of therapy with less of these kind of collateral damage consequences. And so more and more the push will be to move away from long durations of therapy with antibiotics. And so I'll lead off with, or I'll finish up with a couple of comments related to nurses and the impact that nurses bring to antimicrobial stewardship. I think they have a tremendous role in linking a lot of information together and being key stakeholders and helping patients directly in trying to navigate a very challenging situation. Infections are no fun for anybody. I think they can be really challenging to manage in the hospital and outside of the hospital for that matter. And nurses play a key role in a lot of these different opportunities and bring a lot to the table when it comes to antimicrobial stewardship. I think probably the most important, like I said, is being a key resource in synthesizing a great deal of information for the patient and try to make sense of it all for them in that capacity. And so a couple of concluding remarks here. Antimicrobial stewardship is vital for modern healthcare, and the only way that we're going to preserve the utility of antibiotics is to use them better. There's a lot of key attributes of antimicrobials that must be considered to optimize therapy, specifically spectrum, duration, and how they interplay with safety of these agents. And so with that, I'll open it up for any comments or questions, and I'd be happy to share my opinion or insight as best I can.
Thank you, Matt. Great presentation. I am going to open up everybody's mics and cameras, or you can put your questions into the chat. So give me 1 second to open this up. So if you're not speaking, if you can please make sure that you are on mute. And it is saving those settings, so you should be able to open up your mic and ask a question or put it in the chat. We do have one question from during the presentation in the chat already. So how do you know when to go broad spectrum or not?
Yeah, that's a great question. I mean, and that's the real challenge. I think there's a lot of different risk factors that have been identified, and it's about putting it together in an individual patient. I think it really depends on the specific situation. One of the ways that I would try to balance it is the biggest risk factor for antibiotic resistance is previous antibiotic therapy. So if it's a patient that has not been hospitalized, not received IV antibiotics in the last few months, something like that, their risk of showing up at the hospital with a highly resistant pathogen is much, much, much lower than a patient that shows up with recent IV antibiotic therapy that wrapped up a few days ago or a few weeks ago. That patient's at a considerably different risk. So I think that's a big part of it. The second part is I think you have to weigh the severity of illness. If we're talking about septic shock, patients that are clearly in dire straits, for lack of a better term, I think that there's some balance of being broad is probably an appropriate thing to do in that context. Whereas if it's a patient that's more stable in a different situation, they're clearly infected, but not hemodynamically unstable, I think that's where we can be a lot more judicious than we usually are in those situations. So hopefully, that's a quick two-liner, but I think it does depend a little bit about the situation that you're in.
Thank you, Matt. So far, there are no other questions in the chat. Does anybody have any questions or comments? I will be sending out the slides and the recording as soon as I can get the recording downloaded. So sometime today, you will be getting a link to the recording and the slides. Again, we apologize that we couldn't provide CNEs, but the goal of the Sepsis Strike Force Committee is ongoing. We're working on it. So you know how sometimes the going through the red tape is a little difficult, so it caught us off guard. We apologize. Wonderful comments about great presentation, very informative.
Great. Sorry, I had to rush through a little bit of it. So, I'm glad that the slides will get out to everybody. But if you do have any questions, feel free to reach out to me outside of this arena as well. So thank you all. I appreciate the time.
Thank you very much, Matt. Great. Well, thank you, everybody. The Sepsis Strike Force is welcome for members, for anybody that is a member of the Dallas-Fort Worth Hospital Council. That's over 90 hospitals within the Dallas-Fort Worth, North Texas region. So if you're interested in joining the Sepsis Strike Force Committee, the more the merrier, just reach out to me. At this time, we will ask everybody who is not on the Sepsis Strike Force Committee to go ahead and leave the meeting, and we are going to have a 30-minute Sepsis Strike Force meeting. So thank you, everybody.